Hey, good morning, everyone. We're going to go ahead and get started. Hopefully you enjoyed the nice weather this weekend if you weren't in the hospital. So our first speaker this morning is Dr. Yanik Bababekov, who is an assistant professor in the transplant division. He did his undergraduate training at Middlebury, then went on to get his MD at Tufts, where he graduated AOA. He did his general surgery training at Mass General, did his transplant fellowship here, and joined our faculty about a year and a half ago in 2022. He's rotated with me several times, so I know that he's a great doctor, great surgeon, and takes excellent care of his patients. He already has 27 peer-reviewed publications and has been very active in multiple spaces in terms of research. And one of the areas relevant to the residents is his development of the simple application when that company was just getting started. He's really been a wonderful addition to the transplant group here and the Department of Surgery. And I'm going to be giving grand rounds at Mass General in a couple of weeks. I'm going to tell his former boss, Dr. Keith Lilmo, how great a job he's doing. Yanik, please. Thank you.
Good morning, everybody. So we'll discuss pushing the boundaries of DC liver transplantation. I have no financial disclosures, but I am involved in the American Society of Transplant Surgeons. I've been working with others to help develop the technical standards for DCD, normothermic regional perfusion, and also establish a database. So we have a few objectives this morning. We'll first understand the historical challenges of using DCD livers. We'll talk about the modern landscape of DC liver transplantation. And then hopefully I'll prove to you that DCD with NRP is a great innovation that has helped us improve using DCD livers and at the same time improve recipient outcomes. So this is the same for any organ system. The severe organ shortage justifies expanding the organ pool. Just as of last week, there were over 10,000 patients on the liver waitlist. Even though we did 946 transplants nationally, there are still more additions than transplants. And because we do not have a liver for everyone that needs one, 279 were removed because they died or became too sick to receive a liver. Not to mention, taking care of chronic liver disease in the inpatient setting alone costs over $16 billion a year. So to better understand DCDs, let's compare them to other types of organ donors. The first is a perfectly healthy live donor. This is where someone donates a part of their liver. A DBD is someone that's neurologically dead, but the procurement can happen while the organs are still being perfused by a beating heart. And the historical issue with DCD is that this first starts with a patient whose care is futile. And after first person authorization or next of kin, a decision has been made to withdraw life-sustaining treatment in a perioperative setting. And then we wait for that person, the patient, to pass to become a donor after declaration of cardiac death. And so DCDs, by definition, have an additional ischemic hit to organs. There's additional warm ischemia time. You can see first, there's withdrawal of life-sustaining treatment. Then there's a variable period of suboptimal or no flow before procurement can start. And that's different than brain dead donors, even live donors. And so historically, if we look at the national data, DCDs, liver transplants especially, do not have the best outcomes. 65% survival at 3 years, 1 out of 5 recipients would die, and then another 1 out of 10 would need a retransplant. If you looked at what predicted graft failure, it was that warm ischemic time and the ischemic hit to the liver. And so in the next 5 years, you can see that there weren't a lot of DC liver transplants done across the country. It was really just driven by a few centers that were high utilizers. Only 3 centers performed 100 DC liver transplants in the 5 years presented here. And so looking at the modern landscape, we firstly need to understand that things change because of policy. And I think you've seen the UNOS regions before. There are 11 UNOS regions where we had state groupings really out of convenience. You can see Colorado was in Region 8, and that included Iowa and Missouri, especially St. Louis. But in order to help utilize DCDs, we went to acuity circles. Acuity circles entail 3 different types of circles around the donor hospital: 150 nautical miles, 250 nautical miles, and 500 nautical miles. This would help with logistics and help centers within that first blue circle, 150 nautical miles, have first dibs at the DCD at that donor hospital. So looking at the country, if we were just to compare 2 circles, around Denver and Cincinnati, and I love living in the Rocky Mountains and the Mountain West, but there are not a lot of people here. So just by definition, 500 nautical miles around where we are, there are only 18 million people compared to Cincinnati, 100 more million people. There's less potential for organ donors. And if you look at the total number of transplants in Colorado, before and after implementation of acuity circles, kind of stagnated, but you can see the percentage of DCDs increased tenfold. That's different around Cincinnati, where they have a lot more potential for brain dead donors and maybe less of a drive to utilize all of the organs in their backyard, right? So again, in our circle, beautiful nature. Around Cincinnati, a lot more metropolitan areas. And so there has been an evolutionary pressure here, especially for us, to use DCD organs. And so if you look at the modern landscape, the last 5.5 years or so, the number of centers performing more than 100 DC liver transplants during this study period has increased, but there are still almost the same percentage of centers that have done zero. They've not had to do that. So what's helped us use DCDs more? Normothermic regional perfusion. There are other perfusion strategies, and we've talked about these before in this setting. The other machines pictured here are ex situ machines where a liver is procured and then goes on a pump in a liver in a box. Some are more expensive than others, and some allow you to prolong preservation. Here we use transmedics. We have used Organox before. There's a company that's located here actually in Denver or Inglewood of all places called Ex Vivo. We might be trialing their machine at some point, but normothermic regional perfusion by far is the least expensive. I like it because it provides in situ viability testing. We'll talk about that. It's not a device, so it does not need FDA approval. These are wonderful renditions by our first-year fellow, Dr. Maria Bamus-George. So there are 2 different approaches, an abdominal approach and a thoracoabdominal approach. Either work. Here we prefer the thoracoabdominal approach to cannulate right after a patient is declared dead by the cardiac definition. And then the great thing about NRP is it allows an in situ test drive of the organs. So same warm ischemic time period, but right when you make incision, you can go on pump. We do NRP for about 2 hours. This really mitigates the impact of warm ischemia time, allows the liver to generate ATP. We check labs. You can see the liver make bile. And it's really a nice way to find what Dr. Pompicelli calls a good liver with a bad reputation. And so here's what things look like. This was a DCD that took well over 30 minutes to pass, something in the olden days that we would have coded out for immediately, but it's hard to say no to something that looks that great. This is a landmark paper in Age 18, 2019 from Dr. Watson and Dr. Onescu at the University of Edinburgh. They looked at 43 NRP cases and found really excellent outcomes every way that you look at it. We owe a great debt of gratitude to Dr. Needham, who actually went to the University of Edinburgh during COVID to learn from Dr. Onescu and his team and brought a lot of that technology and field strength to the University of Colorado and laid a great foundation. A few years later, the group at Erasmus Medical Center in Rotterdam in the Netherlands, Jeroen de Jong and Dr. Porta, They published a great paper that really described how you can better utilize in situ viability testing to pick good livers from the ones that you shouldn't transplant. And I was very lucky, being supported by Dr. Pomford, Dr. Pompicelli, to visit Erasmus last spring. Actually, the three of us went as part of the International Liver Transplant Society for a perfusion workshop, and we had three important take homes. The first is actually in many countries in Europe, it's against policy, really against law, to use a DC liver without some perfusion technique. In the Netherlands, donors older than 60 that take more than 30 minutes to pass or have a BMI greater than 30, you cannot use those livers without some sort of perfusion. They have a really sophisticated matrix with different labs and perfusion parameters that they check during NRP to help select suitable from unsuitable livers from transplant. We've borrowed some of this from them, and I'll show you that in a moment. But they too, like other centers in Europe, have had excellent results demonstrating a really great graft patient survival and almost no ischemic cholangiopathy. And really, Europe has concluded that the standard rapid retrieval technique without additional protective organ preservation should no longer be considered justified. And so, of course, the United States has seen this data, and unfortunately, we have not yet come up to speed. And the U.S. experience is pretty limited, to be honest. A couple of different reasons. Slow adoption, change is hard. We just went through COVID. There are a lot of logistical travel challenges with travel. We do not yet have a uniform way to collect data for these cases to really study and safeguard outcomes. And still in this country, DCDs they have a bad reputation. This is the bulk of the US experience. This is SRTR data, national data from October 2020 to May of 2022, and there are only 56 described cases. The US data set had to be kind of reverse engineered because there isn't one variable for NRP, but there are only 56 cases described. The donor recipient pairs were low risk. You can see young donor median age, low MELDs. A majority of those MELDs had exception points from cancer, and there are low donor BMIs. Nevertheless, the outcomes are reassuring. No difference in 6-month patient or graft survival. And I guess what I'm most proud to share is that the University of Colorado hospital experience, I think, is the US experience. And I'm proud today to just be a representative of this great group. Our DCD volume has skyrocketed over the last several years. In 2017, we were a low utilizer. In red are all the static cold storage cases we did. 2016, we did 0. During COVID, 2020, and right after the policy changes, we embraced DCDs. That was an evolutionary pressure. And that continued through 2022, where we did our first NRP case as an institution. October 2022 was our first NRP case, and we haven't looked back. And we've even entertained some normothermic machine perfusion cases with Transmedics. This will be the largest published series in the United States. But like all things in transplant, this really started here in Colorado with Dr. Starzl. In 1968, at the American Surgical Association, he presented a series of the first 7 recipients that he said made it through the lethal perioperative stage. All of those donors were DCD donors, and actually case number 7 was a donor that he put on cardiopulmonary bypass for cooling. So not normal thermic regional perfusion, maybe hypothermic regional perfusion. And I know this because this case log sits in the hallway outside my office, and I went through it. And again, all his donors were DCDs, and here's evidence of case number 7 being on bypass. So this all started here in Colorado. We are very lucky to be here at such a supportive institution and work well with our colleagues in cardiac surgery, perfusion, our transplant anesthesia team, the PACU. You'll see most of our livers go to the PACU on the floor. The donor hospitals in the Mountain West have been wonderful, the OPO Donor Alliance, and of course, our mentors across the pond in Edinburgh and Rotterdam. I think something that has been the secret sauce has been Dr. Hoffman, who helped especially me and our fellows learn the thoracoabdominal technique. and our colleagues also, Dr. Kane and certainly Dr. Campbell. There's actually a picture of Dr. Hoffman and I doing a transmedics case just a few weeks ago. And a chance for me to brag about the transplant fellowship. My bias is that these are the two most experienced thoracoabdominal abdominal surgeons in the United States, just given our series, but we really trust our fellows to go and do these donors, technically very complicated, complex, but they've really demonstrated some incredible non-technical skills and judgment and leading teams, certainly in high stakes environments at donor hospitals, and we're very thankful for their help. So this is our matrix. This is something we borrowed from the Erasmus group. We look at several things. We look at different parameters of warm ischemia time. Of course, we try to document how the liver looks, feels, biopsy data. We want to make sure that the perfusion parameters are optimized. We looked at lactate clearance, LFTs, and really want to make sure that there's good quality bile production to make sure that the cholangiocytes, which are actually, I think, are the most sensitive to that ischemic hit, were not damaged, because what people worry about is not a primary non-function, initially a transplant, but ischemic cholangiopathy 6 months down the road. Normothermic regional perfusion is for all the organs. And so we keep track of the other abdominal organs. And then there are two different areas for case comments and feedback, as this is certainly a work in progress. When we talk about outcomes, there's one rudimentary scale called the UK DCD risk score, and it accounts for different variables that have proven to predict some risk. The score is divided into 3 groups: low, high, and a futile group. The futile group is actually what people would suggest are contraindications to using a DCD liver. The ideal situation is using young donors that are thin, that don't take long to progress. Cold ischemia time is limited, and it goes into a recipient that is also young and thin, and of course, not a recipient that would need a retransplant. We've broken all these rules. So looking at our donors, on average, our donors are older. We've gone out to 67, 70 years old. We've entertained higher BMIs, high of 47. Our total warm times go out way beyond 30 minutes now. I think our record is closer to 50 minutes. Again, just to reiterate, when we were first using static cold storage, we aimed for low UK scores. But since doing our first institutional NRP in October 22, we haven't looked back, especially if it's local. Our recipients, on average, are sicker, so sicker donor-recipient pairs. And another chance to brag about the fellows is our warm times are still some of the lowest in the United States in terms of sewing the liver grafts in less than 30 minutes. So again, here's that UK DCD risk score comparing NRP on the top to static cold storage on the bottom. Our low-risk group dominated the static cold storage, but now we've done a lot more high risk and certainly some futile cases. Some of that futile group has included 3 transplants. Again, that's against the rules. One recipient was someone that had a live donor liver transplant over 10 years ago. Another one that we did about 2 months ago had a retransplant, also from a liver 10 years ago. He had a big stent in the right atrium. We need to do a portal vein graft, an aortic jump graft. That was a tough case. Our one primary non-function from NRP was actually saved by a DCD NRP graft. That person's now doing well at home. And we've also entertained some transplant oncology cases. We did a combined liver transplant Whipple also a few weeks ago. That patient's doing well. How do our patients do postoperatively? Well, 60% of all of our DCD liver transplants, almost 80% of all liver transplants go PACU floor. And on the bottom, you can see care escalated to sticky once on floor. And the NRP group, only 6 recipients, 10%. We have wonderful 9-floor nursing, and our APPs are tremendous. Postoperatively, blood transfusions are cut in half. 6.5 versus 3 units of blood, 3 versus 1 units of FFP, less platelets, less cryo. All outcomes are better with normothermic regional perfusion. When we talk about survival, we have excellent survival actually in both groups, reaching 95% at 6-month survival for thoracoabdominal normothermic regional perfusion. In 12-month survival, we now have a cohort we can go out for a year. It reaches 98% for NRP. So this has been an absolute game changer, certainly using organs that we wouldn't have used before. High-risk donor-recipient pairs, still going to the floor, less blood, great outcomes. Focusing on warm ischemia time. In blue are all of the NRP cases we've entertained. Green are the ones we've accepted, and red are the ones we declined. The point of this slide is that I would say it is inappropriate just to code out to decline a liver based on warm ischemia time. You now have an opportunity to take the liver for a test drive in an in situ fashion with NRP. You can see that our graph losses, the X's, were not at the extremes. In fact, almost up to 50 minutes we used a liver after a warm time, and we've declined in the red livers with short warm times. So there's more to the story. Looking at the UK score, those futile cases are at home and doing well. And if anything, the graft losses that we've had were actually technically low risk donor recipient pairings. Some centers in the United States follow lactate and lactate alone. I showed you our matrix. The point of this slide is that it really doesn't make sense. You know, it'd be hard to say what type of a slope you need to follow to pick a liver just based on if the lactate goes down. You can see the graft losses are in black. Those are in the middle. We've taken some with high initial lactates that didn't go down too much. And we've also refused some livers where there were low lactate trends. There's more to the story. Again, lactate is metabolized by the liver, by the Cori cycle, but a liver can be working metabolize lactate despite maybe overproduction of lactate from other parts in the body, the muscle, the heart, the bowel. There's more to the story. And we want to figure that out. So we're going to collaborate with Dr. Christians, Uwe Christians, who is a world leader in metabolomics located on this campus. We're going to try to assess biomarkers of ischemia perfusion injury really related to that first warm ischemia time hit and see how that correlates with outcomes in recipients, and then hopefully in the long term develop therapeutic interventions. What's very unique about this program at the University of Colorado is that we have, I think, the perfect control, a live donor liver allograft that we can follow from a donor to a recipient. So in summary, historically, DCDs had low utilization with poor outcomes. That's changed now with the advent of perfusion strategies and, of course, normothermic regional perfusion. I hopefully proved to you that the University of Colorado and the health system is now a leader in this regard. In the future, we really want to share our best practices to mitigate the organ shortage. There's still some laggards. 14% of the country does not use DCD liver transplants at all. We're going to engage in research, the VAIL study, to better assess allografts, and of course, continue a commitment to train the next generation, really of surgeon scientists. I want to point out Anna Ha. We were really lucky to recruit Anna Ha to work with us. She's part of the Emerging Physician Scientist program. She actually was awarded a scholars year in between her third and fourth year of med school to study with us, and in my opinion, has really formed, I think, the Mount Rushmore of mentors. Many thanks to many people, certainly Dr. Congalvis, who helped with the data analysis, and Joe Lynch-Sacco, one of our lead APPs, who's really helped us take a bird's eye view of the recipient data. And with that, I'll take any questions.
It's in the Cincinnati circle to send us more organs and more benefits.
They're interviewing our senior fellow right now for a job.
It seems like with the new technologies, NRP, fusion, that you're turning things on its head, basically. And it looks like you're foraying into metabolomics, right? And, you know, lactic acid, I mean, that's like an 18th century parameter that we're studying in this very, very high-tech field. And so tell us more about the metabolomics and what some of the promising markers might be.
So there promising markers we don't know yet, but there are certainly different substrates of the Cori cycle that are specific to the liver, and you can pinpoint increases in those that would suggest poor clearance or poor function of the liver instead of overproduction and elsewhere in the body. And that's exactly the point. We're one of the, really the only center in the United States that tries to control the whole process. We go to the donor hospital with their own piccolo machine to measure LFTs, lactate, bile pH, bile glucose to really make sure the cholangiocytes are healthy too. So we're going to look at metabolomics of all of those parameters.
You know, the other problem you're going to have is right now you have what, 98% 1 year graft survival. You know, I don't know what kind of studies you're going to do and what kind of numbers you need, but to improve on 98% is going to be rough.
Hopefully we can utilize more organs, but yeah, you're right, Dr. Schuler.
Anyone else? Rob.
Not really the subject of your talk, but I can't imagine that you get away without talking about the concept of brain death and death itself. And there's been I've seen a lot of editorials and opinions in both the scientific literature, and there seems to be a lot of media about this whole concept of what is death. And when you're doing DCD, I think that brings in that really very, very weighty topic into the realm. So how are you guys dealing with all of that right now?
There are ethical challenges surrounding the definition of death. There are two definitions of death: brain death and circulatory death, cardiac death. Where there is debate is when you initiate normothermic regional perfusion, if there's any collateral flow despite having clamps or ties or venting flow going north to the brain, if there's any collateral flow to the brain that might violate a definition of brain death, or that you might be violating a definition of circulatory death. I do not subscribe to that, but we are going to look at another study actually called the NeuroNRP study that our center will lead to look at the impact of electrical silence, looking at EEG waves on NRP, flow to the brain. All of this has already been disproven in Europe, and we're going to do that here in the United States.